Ladies and gentlemen, please welcome our host for tonight, Miss Ophelia and Player Fraser, class of 1980, the chair of our Bylaws, Policies, and Procedures Committee.
Hello, hello. Welcome, everyone. Welcome to our monthly Sumustahan. As you can see from the flyer, we have two speakers for today, but because of urgent matter, Dr. Milo can't join us today, but he will try and present at another time, which means we will have more time spent with Dr. Jennifer Garcia-Tolete. She is our very own 1994 graduate from St. Louis.
Thank you, Ate Offie.
Yeah, Dr. Tulete graduated in 1994, and that's not enough. She went on to pursue her degree in medicine, and she completed it, of course, from St. Louis in 2000. And she came here to the US in 2001, and she occupied various positions from various healthcare facilities, from nursing home to rehab to ICU. So she was a staff nurse, she was a supervisor, MDS coordinator, and also director of nursing. In 2007, she joined Kaiser Permanente in her current position right now for the last 15 years as in telehealth medicine. This is something that we are also familiar and that we are also unfamiliar. And I myself is really envious about it. So hopefully we can learn more from Dr. Garcia-Tolete and be inspired to join her current position. Let's give her a big welcome, Dr.
Thank you so much for that nice introduction. Good morning, Philippines. Good evening, everyone who is watching us today in this part of the world. My name is Jennifer Garcia, and I am a true Louisian by heart. I'm very honored that I was invited for today's topic, which is very timely. And thank you for allowing me to share what I know in this specialty care of nursing and medicine. And yes, I have been doing this for the past 15 years. I know it's been a very long time, but yeah, I can say that before telemedicine became this big and huge and massive, I was already doing it. So, what is telemedicine? I will just make it very simple, and it's just a delivery of care, which is giving care remotely using electronic communications. So there is no telling far and wide how this field of healthcare industry expanded tremendously throughout the years. And thank you to technology. So we cannot discount that technology is changing every aspect of our life. It plays a central role in our everyday activity, whether at home, at school, or at work. And technology has actually redesigned the healthcare system, which significantly created substantial improvement in the quality of care. So we all know how COVID-19 pandemic wreaked havoc our healthcare system. So to prevent risk of spread and to reduce a burden of to our hospitals and to our workers, which are who are already overwhelmed during that time, depleting our medical equipments, our human resources. Telemedicine has been in place and become like a forward triage and a form of providing care, which was the spotlight in the last 2 years. So thanks to coronavirus, virtual medicine was born. So if you can see my slide, I would like to start with the evolution of telemedicine. So I'll do this very quick. Um, in 1879, it has been seen in the readings that telemedicine has been used when patients are remotely located. So doctors call their patients through telephones or probably radios just to reduce their hospital visits at the time. In 1905, the invention of the EKG, which was discovered by Dr. Einthoven, a Dutch doctor, he paved the way to modern medicine when he was able to produce an ECG tracing on a paper. So um, this is a form of telemedicine. It revolutionized telemedicine in the hospital setting because that form of paper can be relayed to another doctor at a different area, and they can interpret, they can provide, a treatment plan. So that's a form of telemedicine in the early 1900s. In 1925, it has been seen that there was a magazine where they showed a doctor, an image of a doctor diagnosing a patient from a distance with a radio. And that is a form of telemedicine at the time. Another example was in Alaska, where we all know that satellites, this in Alaska, there are small healthcare satellites where patients go, and when they have to be taken care of, or if they need like further care, like a higher level of care, they have to be flown to Anchorage to get the care. So all these doctors and nurses in the smaller units have to collaborate with the specialist through the telephone or video, so that they make sure that these patients really need to be flown, because that's a lot of trouble. So they can, or they need to just be taken care of at where they are. So that's how it's being used in the early 1900s. In the 1960s, it has been also used in NASA, where physical, physiologic changes in the astronauts or patients in the ships, like in the military ships, have to coordinate or talk to doctors on the mainland to be able to diagnose patients who are ill in those facilities. And then 20th century came, and we have seen a massive impact of information technology and health related software at the time, right? We have witnessed, because I was here in the 20th century, like 2010 maybe, we have witnessed the inevitable migration of medical records becoming electronic and digital at the time, which was a wonderful change. Imagine those days when we had to write nursing care plans every shift, being written up for medication errors because of incorrect transcription, because we all know how nice doctors' orders could be. They can be ineligible, and sometimes you have to guess, and that poses some risk for errors. And then getting orders over the phone for like vague verbal medication orders from our doctors, those things are gone now. With all records being digital and electronic, our job, at least with regards to charting, has become less labor intensive. So in the last decade, we've also seen like mobile health apps, like phones, or even Apple Watch now can detect your oxygen saturation or your EKG. How wonderful is that? Um, and then I have seen also how we have to send our patients to Walmart or to the stores where our hospitals would have like kiosk, and patients would go in there to be able to access the doctors through a video, because during that time in the early 2010s, not everyone has like smartphone, not everyone has access to internet. So those kiosks were in place as a form of telemedicine at the time. And then we also have like wearable sensors and monitors, which helps with better monitoring. And these are like, Bluetooth Holter monitors, glucometers, which are connected to the doctor's offices. And in a way, it allows better monitoring of patients. So I have been in this specialty since 2007. I work for the biggest health maintenance organization, or HMO, in the United States, in the name of Kaiser Permanente. Actually, I made it here due to an unfortunate event which turned out to be a big blessing or a beautiful accident. But that will be a different story I will tell later on. So before I did this job, I was working as a DON at a 325 bed subacute and rehab skilled nursing facility. I wanted a change and I was yearning to be challenged because I just got out of medical school. I wanted to see what it's like to be in an American hospital so I can put all of my 10-year knowledge of schooling in medicine and nursing into practice. So I jumped into the hardest battlefield of hospital. I jumped into the ICU where I saw everything and got trained and developed my critical thinking and medical and nursing skills. But then I got injured, unfortunately, and got me incapacitated for a while. So I thought, I had to do something because it's kind of depressing at the time. But one day, my coworker gave me a flyer, and this was in 2007, and a flyer from Kaiser Permanente saying, "Are you a nurse with aches and pains? This is the right job for you." So it's like, wow, okay. So I went and I found out that when I entered the training room, I was the youngest in the group. So my coworkers were nearing retirement, and it was like, is this the right place for me? But then 15 years after, and I'm still here, and I feel like, yeah, and I'm gonna tell you why, I'm still here. Our jobs were actually created to prevent our Kaiser, so that our members, because Kaiser Permanente is like an insurance who provides its own hospitalization and care. So for the members to avoid calling 911 frequently, which could be very expensive, they created our job. So we are like available 24/7 in place for our patients to call, so that they will know when they have to call 911. So they can tell how grave their symptoms are and if it's really necessary to call 911. So we were made accessible to our patients to manage 911 calls at the time. And eventually it became an access to all patients with concerns or red flag symptoms while they are still at home. So while they are still at home, we are already triaging them. In that way, we can immediately determine the urgency of the medical issue, and if it is indeed emergency, or it is safe to delay care, or they require just home treatment, we give them that advice. So we triage the acuity of symptoms, direct them to accordingly to the right level of care, to the right facility that is capable of handling that symptom in a very timely manner. So that's really what I do and what my job is usually. So as triage and advice nurse, we can navigate and prioritize interventions for this patient. So in a way, I don't just talk to the patient, I also collaborate and coordinate with the doctors at the hospital. Like patients who just came from the ER, I don't want to send him back again. I just have to call the hospitalist and tell them that this is the situation of the patient. Does he really need to go, or we just have to change medication? I could also coordinate the care with the surgeons to make sure that what the patient is expecting is really something that's expected from the surgery, or now he needs to go back again at the ER. So this way we are trying to avoid patients crowding the emergency room and avoid flocking of patients to urgent care, because sometimes these patients really don't need to be there. And if they're not so urgent, the situations, we schedule the appointments ourselves, message the providers, screen them for prescription for medications that simple UTI, simple sinusitis, simple conjunctivitis. These things doesn't need to go to the hospital anymore. We can just screen them, and if they're safe to go get their medication, the nurse practitioner will be able to prescribe this medication. They can just pick it up. So that's a good thing about telemedicine. It has expanded from just calling patients and following them up, and now trying to organize their care. And it is something that makes you become an integral part of the healthcare system. So before 2020, um, maybe we can do the next slide. We would roughly have like 3,000 calls per day. And that was a lot when I started. And imagine when 2020 COVID-19 struck globally, suddenly my low profile job became the new face of the healthcare industry. We probably like tripled or quadrupled the number of calls at a time. And as COVID-19 was rising, we couldn't discount the fact that we still have like other patients who need to be taken care of, and we need to take care of them without having to be exposed to the COVID-19. So hospitals and facilities being burdened by the significant number of cases of COVID-19, everyone has to change from in-person visit and shift to telemedicine right away. So boom, telemedicine takes the spotlight of the healthcare industry. So I'd like to start virtual medicine with the methods that we do. I already told you what I was doing at work. So what I usually do as a method, and I'll only tackle 3 things, which are very common, is the live interaction. We do that as a telephone or video, which is usually what we do. So we assess the patients on a real-time basis. Secondly, is asynchronous and store forward. So this is like a supportive thing to the first one, to the live interaction, because imagine what these patients are telling you. It's sometimes hard to picture, like a rash or like the wound, how it looks like. And if a patient is really in distress, you don't want to make mistakes from not looking into some of the details, because sometimes they describe it so grave or so lightly, and it's not the true symptom. So we have what we call the store and forward data, where I can request for pictures, I can request to view them through a video, and we do that while doing the care. So these are things that they can also send to their doctors, and it is a big help. So because it really solidifies or gives you right decision making when you have all this information. And then lastly, the other form or method of telemedicine are the remote monitoring or the wearable stuff that I was telling you earlier, those devices. And yeah, those are pretty easy to understand. All right. So the challenges of telemedicine could be identified as on the side of the patient or the nurses. So I did this way so that it's easier to understand. When telemedicine was being put in place, there are a lot of hesitations. So patients' acceptance and preference is one of the many challenges that we have to face usually, because there are many factors that can influence their adoption of the virtual care patient-wise. So one would be about being assessed and advised over the video or phone. And we all know that patients are used to being in the hospital or being in the clinic where they are face-to-face with their providers. So we can all agree that sometimes, and it's true that virtual assessment is not incomplete. Not all diseases, not all conditions are appropriate for virtual care. And it also boils down to the trust, the trust that is between the patient and provider. So when you are not face to face with with the patient, it's hard to build and establish that trust. And every time there's no trust, they feel like they're not getting care. So they just feel safer and more confident when they are face to face with their provider, and that's something that you have to overcome as a challenge. The next one I have here is digital literacy. So that's a very common problem, and it's expected. So those group our elderly group, the disabled group, not so techy or savvy individuals. Sometimes there's disparity in the delivery of care and their access of care in this patient group. And then secondly is not everyone has access to internet. Some of our patients could be homeless, they don't own a smartphone, they don't have any internet access. So not everyone will be able to access this care, and it limits our ability to provide what they need. And then last but not the least is that challenges patients and nurses as well is the limited language proficiency. So with the limited language proficiency, you know, it's about English as being their um, as English as not their primary language. We also have patients who are deaf and mute, and all these limitations of being able to express yourself and understand the healthcare workers and vice versa poses greater risk of miscommunications, frustrations, unsafe triage, and inaccurate recommendations. So just be aware that there's an increased chance of nursing malpractice in relation to this challenge. However, there are other things that we can do. We can provide language interpreters. We have relay callers as well to help us. So we just have to access what we can do to provide the best care for our patients. And then the next one will be the challenges for us as nurses. Nursing care is provided virtually with telehealth. And sometimes, again, it's perceived as a poorer quality of care. Going back to my explanation earlier that not all symptoms or diseases can be addressed, assessed, and treated over the phone. We are also, it's gonna connect to the perception of, not being able to connect with these patients. There's an impersonal interaction between us. So sometimes, they will just tell you, oh, you're just a nurse, I don't want to talk to you, I want to talk to my patient. So I always encounter those instances. And then the next one is the HIPAA, Health Insurance Portability and Accountability Act, privacy regulations. And working at home, it increases your risk of inappropriately disclosing information at anyone at home. So you want to make sure that you're always, locked in your room. Nobody is walking around the house listening to your conversations, because you are violating HIPAA if that's the case. And then another thing is that when you talk to these patients or you get information from them and you ask for pictures or videos, you cannot use Skype, you cannot use FaceTime, you cannot use messengers or private text, because those are not the platforms that are protected by your organization. So you have to use what is approved by your organization. And then the fourth one would be communication barriers. And I already talked that earlier. But as a nurse, you should always offer medical translators or relay agents to help during the triage. And sometimes we don't want to use family members or as interpreters because we don't want to avoid bias and misinterpretation. So always offer medical translators and relay agents. And then number 5 is something that I'm always scared working because of the risk of malpractice. We all know that the scope of nursing as a whole, whichever department you are, whether you are in the specialty department or whether I'm at home 100 miles away from my patient, we carry the same liability and responsibility. So my obligation to that patient, whether I'm just over the phone, is the same as the person who is at bedside. So it carries the same weight. And so every time you have to do this assessment, there's always risk that you are missing something. Imagine giving care or nursing care to these patients and you cannot touch them. You cannot listen to their breathing, or you cannot see what they're describing, because sometimes videos are not available. So imagine doing nursing care blindly and you're only basing your recommendations, your nursing care decisions, from what the patient is giving you. um, it gives you some, you know, chances. You like, it allows you to have rooms for error. So it's always a challenge, that, you know, I encounter every day. So it's something that you have to learn how to be able to clarify, quantify, and qualify information from your patients, because there's risk of malpractice. Because in our work, we usually have all all um, all encounters, all communications are being recorded. So when things go wary and patients are not satisfied, you know, legal issues arise, and all these communications are recorded. So they can always go back to those recordings as evidence. So the what you need to do is that you remain consistently thorough, using always your critical thinking, but still remaining nice, still remaining helpful, even when your colors turn aggressive and irate against you. And I tell you, that's very hard to do, that to stay nice and helpful when they're already cursing you at the other end. So that's one of the challenges I always face every day. And then number 6, for 15 years, of course, I have experienced so many phases of burnout from this job, because working telemedicine, I work from home. I have worked from home since my 20-year-old was 4. And if you work from home, you don't have any work friends. So my work friends are my husband's coworkers. And if you work from home, you are also isolated from your workplace. So the stress that comes with this work is more mental and more emotional rather than physical, like those nurses at bedside. Because you deal with these patients, you deal with different patients every call. So you don't know what's gonna come from the next call. And it's a range of a different disease entities. It's ranging from a newborn to geriatrics, from different specialty department of gynecology, cardiology, surgery. So it could be very stressful, because after 2 minutes, you have to switch your mind to another field. And that can cause you a lot of burnout. So you just have to learn how to cope up with those things. And for the past 15 years, I've learned how to do so. Um, and it can be very exhausting as well to be talking for 8 hours straight, and then you have only 2 minute 2 minute um, idle time in between calls, because with what I do, we are being monitored through statistics. So nobody is like watching you from home. Nobody is like monitoring you what you're doing. So they look at your productivity through the day. And yes, that can be one way of getting burned out, right? But eventually you will learn, and um, as you go along, you will adapt to it. And right now, it's like an easy task for me, and I can do this now with my eyes closed, maybe. So, because it's been 15 years. And lastly, the last challenge there is being open to the rapid change of technology, because technology is like changing constantly, you know, and we have to adapt with this changes in healthcare. So for the past 15 years, like after a few years, we have a new phone, I'm on a phone line again, or we use a different software again. So every few years, you have to relearn and keep up with this innovations, which is always improving. So those are the challenges. I've saved the best for last, and which is the perks. And that is why you probably will say, oh, that's why Jennifer is there now for 15 years. So what do I really like about this job? First, we all know that it's about, it's getting remunerated, right? I took this job because I had, a house to pay, have kids to to raise, and because I couldn't go back to the nursing, at bedside at the time because I was injured. I took this job, and it was good because our remuneration is the same as those people at bedside, because this one is considered as a specialty department. It's a specialty branch. So when nurses in the bedside during the pandemic are receiving incentives and raises from other departments, we also get the same because we are considered a specialty branch. And because the demand is so high and only a few are trained to do so, you can work as many hours. There's like a lot of overtimes if you are a workaholic like me. So the remuneration is really good. I can actually vouch also that there is definitely job security in this branch of nursing. So if few years ago it was deemed like the future of healthcare, now is the future is here. Telemedicine is now here to stay. So I believe that when the pandemic becomes under control within the next few years, I don't think telemedicine will go away. It will be here to stay. So there's job security in this department. And the other one is one call at a time. Yeah, so it when you have these patients, and this call you're taking right now is just so hard, I always keep in mind that this call shall end. So even if it's really stressful and it's a hard call and patients are irate, you just take things one call at a time. So I would say that it's not as bad as having 4 or 5 patients in the hospital at a time calling you. But with telemedicine, you just have to take care of one call in that period of time, and then the next one comes along. So that's the good thing about it. And then I work from home. So a day in my life as an advised nurse starts with, if it's not weekend and it's weekday, I can wake up and cook for my family, get them ready for school, and then I go to my office like maybe 3 minutes before my login. So that's how I start my day. And when I go to work, my kids go to school, and when they arrive from school, I'm done with my work and I'm home. So that's the beauty of working from home. It's considered a privilege, and that's why telemedicine is so, it's like a privilege. So it is something that attracts a lot of moms or working moms like me, and it's just a very good way of being still able to earn, but you can align your schedule in a way that you can take care of your family. And now it saves me a lot of time, effort of traveling to and from work. You save time, especially now. I'm so grateful because imagine how expensive gas is right now. It's even more expensive than a venti Starbucks, right? So I don't get to spend gas because we work at home. And then we're almost done. And then the number 4 is um, reducing physical stress and exposure. So it's all about safety. with this job in this time of pandemic, you still get the chance to help humanity without having to, you know, stress yourself and put yourself at risk of being exposed out there, especially in this time of pandemic. So with this job, I'm very, very grateful because I still help humanity. I still feel the fulfillment of being a nurse and still get the privilege to be called a healthcare hero. But I am remaining in the safety of my home. You know, I am safe in my own bubble at home. So although you are stressed, you know, with the calls that's coming in, it's not as bad as those directly working in the hospitals. And you know, that's where the battlefield is. That's where you get all the stress. And I feel for that because my brothers and my sisters work in the hospital, so you know, I feel what they're going through. So it just makes me more grateful and look at the bright side that, you know, I can work from home, not in the nice figs or nice clothings, but in my comfy pajamas. And because we don't have to dress nicely because the patients doesn't see us. If you have videos, it's just a one-way video, they don't see us. So it's not like mandatory. And then you can get to work whenever you want. And it's a gift and it's a blessing. I'm trying to savor right now, especially in this time of pandemic. And when before I thought that it was like such a boring and like an end of career kind of job, and now I feel like God has put me here, and now I see the meaning of, you know, um, why things happen, you know. So I wouldn't want it in any other way. I feel that this is a gift. So that's all I can say about telemedicine. I hope that you have been inspired and had like a glimpse of what I do and what telemedicine could be. So I hope that any one of you can join me in this side of nursing. It's not so bad. I'll be more than happy to ask any questions if there's anyone who has anything to clarify at this time. That ends my discussion for telemedicine. Thank you so much for listening. Oh, okay, I forgot that. So in the when you are a telemedicine specialist, you are not required to have like CPR or pulse or other certifications to work. So that's the good thing. I don't have to do those things. But when you need certification to work in the state that you are working at. So for example, I work as a nurse here in California, but because our hospital has like other, we have hospitals in different states. I could be certified for Hawaii, for Georgia, for Oklahoma, and for California. So that is something that you have to be certified. But with the other certifications, I have to clarify that those are the ones that's needed at the hospital, and I don't have to do them. Any other questions?
Um, Jen, this is Chris.
Hi.
Can you let everyone know about the protocols and what we follow as far as the succession of triage?
Oh yeah. So we have to follow a guideline with regards to triaging because we have to be in the same page as nurses when there's a certain condition. So protocols are being followed, and this was established by our doctors. That is also being used as a triage protocol in the emergency room and all the other healthcare, different departments in the clinic. So there's a triage protocol in place that we follow. That, for example, a patient has a chest pain, then there's a certain things and detail lines that you have to ask the patients, and that guides you to determine the dispositions for these patients.
Yes, thank you so much for this. Yes, we have to share. Next slide, Manette. So we have our updates. We are really bummed that we really have to change the date for our reunion, our first reunion. It's now moved to July 13 to 15 in 2023. It is because of this changing landscape, and you will never know what's really happening. So because of this COVID, so we need to change that. It will still be in Sheraton Vancouver World Center in Vancouver, British Columbia in Canada. So we're really looking forward to this. Hopefully, our main goal is for us all to be safe. That's the main reasons why we have to change the date after a really long deliberation. Next slide. And of course, for those who are not a member yet, please join us. You know how to do it, and we have our website. It's the www.slunai.org.
Right.
You'll never know what you're missing, and just more updates. This is our scholar featured here with Dr. Dino Doliente. Her name is Jamie Mortel. She's been doing very well. Thank you to our benefactor. She's now in her third year, and next year she will be graduating. Hooray for her! And thank you to our donor for this. Next one. Oh, yes, it's worth mentioning again. We are now a 501c3 nonprofit organization, which means any kind of donation will be tax deductible. So keep it coming. It's really going for a good cause. Thank you. I think that's it. Stay tuned for Chikahan. Thank you all for joining us, and for those who are leaving us now, join us again next month.